couple of announcements, ladies and gentlemen. If you want to buy books, this is your last chance to take a look at that selection of books. Also, some of you are leaving early. As a matter of fact, some of you have already left early. And I want to make it, we're going to send you a thumb drive with all of the lectures from today, so that if you missed anything or anything like that, you'll have them independent of when you leave. And that is the messages. Artie? Thank you.
Okay. I'm back again. And this is our final orthopedic lecture, the hand and the wrist, and one of the last lectures of the whole conference. So let's dive right in. I'm going to say that I have kind of mixed emotions about seeing someone with a hand or wrist problem pop up on the tracker. On the one hand, I'm thrilled it's not dizziness. It's very focal. It's an external exam. But on the other hand, I know how high stakes these injuries are, and a missed injury resulting in decreased grip strength or inability to work is really quite devastating. And we use our hands from the moment we wake up, and we check our texts and we check our emails and we make a cup of coffee throughout the entire day, and then again when we're like pulling the blankets over you at night. So our hands are absolutely vital. So it's really important that we don't miss any of these injuries. Today we're going to go over the anatomy and the approach to the exam and some common injuries. I want to again put a little asterisk and say be really, really careful about these exams in your patients that are intoxicated or altered, as we talked about with the compartment syndrome. You know, we have a tendency, if you see someone with blunt head injury while intoxicated, you're so focused on the fact, do they have a scalp laceration? Do they have bleeding within their brain? Are they sober enough that I can give them a sack lunch and they can walk out of here, that you forget sometimes to look at the hands and you miss, a tendon injury or a broken bone or a laceration. So just take extra caution in those patients. So let's discuss the hand and wrist anatomy. And I think of fingers in the same way I think of teeth. Never in a million years am I going to learn the numbers of teeth. I'm just going to name them. This is the central incisor, this is the canine, and I feel similarly about the hand. So rather than having confusion, is this the second finger or the third finger, just call them the thumb, the index finger, the middle finger, the ring finger, and the small finger, and that avoids any confusion. Also, rather than using medial and lateral, so when you're talking about medial and lateral, is it in this position? Is it in this position? Just simplify things. Anything closer to the thumb is radial. Anything closer to the small finger is ulnar. So this is the radial aspect of the thumb, the ulnar aspect of the thumb, the radial aspect of the wrist, and the ulnar aspect of the wrist. Back of the hand, dorsal. Front of the hand, the palm of the hand is volar, and then you have your joints, your interphalangeal joints, your DIP and your PIP, distal joint and proximal joint, and these fingers. The thumb has only one joint, so it's just the interphalangeal joint, and then the MCP joints here. Now, when we approach the exam of the hand, we usually think about these three main nerves, the ulnar, the median, and the lateral. For each one of these nerves, we want to check sensation and we want to check motor. So how do we assess sensation of these three nerves? Usually what we do is we pick some distal point within each of those distributions, and we assume that if the sensation is intact distally, then probably the rest of the course of the nerve is relatively intact. So for the radial nerve, I just touch over the snuff box. For the median nerve, I touch over the volar aspect of the index finger, and for the ulnar nerve, the volar aspect of the small finger. So radial, median, ulnar. And as a small note of finesse, instead of asking, do you feel this? I ask, does this feel normal? Because if you ask someone, do you feel this? They might feel it, but it might feel abnormal to them. Maybe there is a little bit of decreased sensation, and you're not going to pick that up if you phrase the question that way. So does this feel normal? Does this feel normal? Does this feel normal? I'm done. Now, talking about motor innervation of those three nerves, the median nerve is thought of as a tea drinking nerve. So a lot of us do this okay sign. Just remember that you have to actually make them do this. They can't do a shadow puppet. This is actually an abnormal median nerve. They need to do this, this okay sign, and then I kind of pull at resistance. And to be thorough, I also check thumb to small finger, and that kind of gets the entire median nerve. The median nerve, why is it the tea drinking nerve? So it's pincer, wrist flexion, elbow flexion, and pronation, everything you'd need to drink a cup of tea. The ulnar nerve, you have two options. You can do crossing of your index finger and your middle finger, or you can just ask the patient to spread their fingers and resist you pushing the fingers together. And those are your intrinsic muscles of your hand. The radial nerve is quite simple. Those usually do all of the extensors, and you'll just ask the patient to stop traffic. And if they can do this, the radial nerve is intact. If the radial nerve is out, you'll see patients coming in with a wrist drop. And actually, it's funny, I work at a place where they call out of code strokes, and I frequently get called to assess a patient as a possible code stroke candidate. And it's often somebody who's, maybe they fell asleep on the couch for a nap, and they fell asleep like this, and their arm was draped over the side of the couch, and that radial nerve was getting compressed, and they wake up, and all of a sudden they have hand weakness. And so when I go to assess them, the grip is strong and the flexors are strong, but they just have a floppy wrist because they cannot extend at the wrist anymore, and they have a radial nerve injury, and this is not a stroke. So let's move into talking about the flexors of the finger. So on the dorsal aspect, you have the extensor tendon, and unfortunately, kind of like the shin, there's just not a whole lot of padding. If you feel your own finger, it's just basically skin, and then it's the extensor tendon. So those are really vulnerable to injury when we have lacerations to the dorsal aspect. The flexor side, we do have a lot more padding, but this flexor system is quite complex. It's a whole series of pulleys, and for every single finger, you have 2 flexor tendons that need to be evaluated. You have the flexor digitorum profundus. That's the one that profundus runs deep all the way to the DIP and flexes at the DIP, and then the flexor digitorum superficialis, the FDS, and that one just helps with flexion at the PIP. And the important thing is when you're assessing these patients for a flexor tendon injury, you have to examine each one of these tendons individually for every single finger that's affected. The flexor tendons are so important. How many of you have seen the movie where Alex Honnold, ascends the face of Capitan about 900 meters, and he does it all with his flexor tendons? Or, concert pianists. We need these flexor tendons. So, to test them, how do you do it? So I want everyone, if you can, to do this with me. We're going to test the flexors of the ring finger. So first, to test the flexor digitorum profundus, so that's flexion at the DIP, you have to take the FDS out of the picture. And the way you do that is by clenching and clamping that PIP between your fingers, and then you're just going to ask them to bend the finger. And that way you're just going to have them bend at the DIP alone. Now, checking the FDS is a little bit more complicated, and that's when you want to assess flexion at the PIP. So you need to take the FDP, the flexor digitorum profundus, out of the picture, and the way you'll do that is actually to take the small finger and the middle finger and the index finger and hold them in extension. So if you can do that with me right now, and then ask the patient to flex their finger. And how many of you are able to flex at the DIP? Can anyone do it? None of you can, right? But we all have an intact FDP. So that means that we have successfully taken the FDP out of the picture, and we're just assessing the FDS. So that's the way you assess those 2 tendons, and you have to do that for every single finger that is affected. This is a quick summary, again, of that motor and sensory examination of the 3 nerves. Does this feel normal? Radial, median, ulnar. And then for median, it's that okay, and touching the small finger. Radial, stopping traffic, and then ulnar, you can either cross your fingers or spread them out. So now let's move into some injuries. So a tuft fracture. This happens when you're nailing something in the wall and maybe the hammer misses the nail and you hit your finger, or you drop something heavy on your finger. And for the most part, these are really benign. These are fractures of the distal part of the distal phalanx. And for the most part, they actually are treated kind of like soft tissue injuries. There's not a whole lot to do. If they're open, there's controversy about whether to give antibiotics. For the most part, they're not recommended, but use your best judgment. Maybe your patient is diabetic or was kind of a dirty crush injury. You can consider them. But what I do is actually send them out in a fold-over splint, and this is just for protection. It's not for healing. It's just so that when they sort of go and they hit their finger on something, it doesn't cause them a lot of pain. But make sure when you do that fold-over splint, you're not unnecessarily mobilizing the other joints of the finger. This is just for cushioning. Now moving a little bit more proximal in the finger, we have the mallet finger. And the mallet finger doesn't help me to remember what happened, so I instead call it the baseball finger. And what happens is, say someone throws a ball to you at a high pace, a basketball or a baseball, and you're trying to catch it and it stubs your finger, and in the process it hyperflexes your finger at the DIP. And what happens then if it hyperflexes there is that extensor tendon at the DIP can just rupture. And when it ruptures, it can also pull off a little piece of bone and cause an avulsion fracture. If these are missed, you'll see this swan neck deformity here in this picture, so you don't want to miss them. And the treatment is actually quite simple in most of the cases. You're going to, again, give a fold-over splint. You're going to keep that DIP in hyperextension. don't immobilize the PIP, let that free, and you're going to tell the patient that I don't care if you're swimming, I don't care if you're taking a shower, I don't care if you're sleeping, that splint doesn't come off because it has to stay in extension for 6 weeks. And if they take it off, if they cheat, the clock starts all over again and they have to do that 6 weeks all over again. So they put that in extension only in some cases. If the fracture is quite large or quite intra-articular, then maybe they'll consider surgery. But for the most part, you just have to splint them in extension. So while you were nailing, into the wall and you hit your finger and you cause a tuft fracture, you might also develop a subungual hematoma, and that basically refers to blood underneath the nail. And if you think about it, that space between the nail and the nail bed is really small. So any blood that accumulates there can cause a lot of pressure and pain. And relieving these subungual hematomas is so satisfying. It's really fun to do. I think of it almost like taking the earwax out of someone, who has cerebellar impaction and giving them the gift of hearing again. And so it's quite fun and easy to do, and there's a couple of different ways you can do it. If you have electrical cautery in your ER, that's great. That's the easiest. You sort of put it over the area of maximal hematoma, let it heat up, and it creates a hole, and then you push on the nail, and all of this blood comes rushing out. If you don't have that, you can also use an 18-gauge needle and sort of twist it back and forth to bore a hole in the nail. These shouldn't be painful, so I usually don't block the finger, do a digital block of the finger. The times when I see these being painful is when the person using electrical cautery or the 18-gauge needle is pushing too hard, because eventually you're going to pop through that nail, and you're going to pop through the nail with either something sharp or hot. So don't put a lot of pressure when you're doing this. But these patients have immediate relief after you relieve their hematoma. Again, talking about injuries to the distal part of the finger, the evolution of our management to nail bed injuries has been quite profound. Back in the day, if you suspected a nail bed injury, you would take off the entire nail, and then you'd go through this really onerous process of having to repair the nail bed and then figuring out how to put something back on. And it turned out that that usually is not necessary. If the nail is still anatomically in the right place, it's not elevated, just leave it be. Less is more, even if you suspect a nail bed injury. But if the nail is very avulsed or is transected and you do need to do a nail bed repair, so you're going to remove that nail, you're going to go in and repair either with absorbable suture or Dermabond is a great option. And then the important thing to do is that you've got to splint open that area underneath the cuticle where the next nail is going to grow. Because if you don't do that and that sort of gets adhesed down, then that patient's nail is not going to regrow and they're going to end up with an accent nail that they don't want. So splint that open. You can use the patient's own nail, or you can use the packaging from a suture material, whatever it is. But let them know the nail's not going to reappear overnight. They grow about 0.1 millimeter per day, so it's going to take 3 to 6 months, more likely 6 months, for that nail to regrow. Trigger finger is quite a fun and easy diagnosis in the ER. The patient's going to come in and say, you know what, my finger's getting caught in this position, and I have to sort of wrestle it and wrest it back, and all of a sudden with a pop, I can get it back into extension. It's not a diagnosis you're going to miss. It frequently affects the ring finger and the thumb, and the thumb we're seeing a lot more of because it's actually as a result of texting. It's called a texting finger, and really there's just some scarring or a lump that's developed in the flexor tendon sheath that causes that finger to catch in position. Not a lot for us to do, but an easy diagnosis to make, and if it really persists, they can go to an orthopedic surgeon for steroid injection or other sort of surgical management. So now we're moving into infections of the finger, and for anyone in the audience who is a former nail biter like I am, you've probably had a paronychia in your lifetime, and those are the infections just around the nail fold itself. And so if you just have erythema alone, usually these do fine with just warm water soaks, and you don't need antibiotics at all. If they do start to develop purulence, as you're seeing in this one on the right here, they will need to have that pus relieved. So when they come into your ER, you're going to do a digital block, and you're not actually going to slice over that area of purulence as we do in most abscesses. Instead, you're going to run a scalpel or an 18 gauge along the nail and sort of lift up the nail fold. And as you separate those layers, the pus is just going to come streaming out, and I'm always shocked by how much more pus comes out than I was expecting. These usually don't need antibiotics. Once you've relieved the purulence, that you're kind of all set. Felon, on the other hand, that's an infection of the pulp or the pad of the finger. These need to be cut into, and you actually need to cut into them because there's a lot of septations there in the finger, and infections can sort of hide away and not be treated with antibiotics. So you're going to incise and drain these, and you're going to send these patients out with oral antibiotics. What you don't want to cut into is herpetic whitlow. And so you might be wondering who gets a herpetic infection of the finger. And it's really anyone that's making a lot of contact between their finger and their mouth. So the one category is kids, right, the ultimate auto-inoculators. And then the other category is healthcare professionals, actually, and frequently dental professionals. So just a reminder to wear gloves. And if you do see these, if you look really quickly, you might mistake those vesicles for pus. Be really cautious when making this diagnosis, because if you cut into it, you can actually worsen things and cause herpetic myositis. You just want to throw them a course of antivirals and call it a day. This is one diagnosis that we cannot miss in the ER. If you miss the Paronychia, if you miss the Felon, and they come back a couple days later, probably things will be okay. This is one that needs to be picked up immediately, and this is FTS, Flexor Tenosynovitis. So what happens is there's some puncture wound, there's some laceration to that volar aspect of the finger, and it's gone deep enough that it's violated the tendon sheath. So now bacteria are introduced into that tendon sheath, and the infection can sort of spread up and down the finger. If you're thinking about this diagnosis, you're thinking about the Knavel signs, and you can memorize them, but they're all really, really intuitive. So the first one is you have an infection of the finger is swollen. That makes sense. The second one also makes sense, right? So you have an infection of the tendon sheath. It's really inflamed. It's irritable. It certainly does not want to be stretched out. It wants to be in a position of comfort. So the patient is just going to hold their finger kind of flexed like this. And if you try to stretch that finger and put it into extension, that's going to irritate that infected sheath. So they're not going to like that. And the last one that obviously makes sense again is that their tendon sheath is infected, so it's going to be tender along that sheath. If you suspect this diagnosis, this is a call to the orthopedic surgeon immediately. This isn't a send them out with oral antibiotics. And when they come down, I'm always shocked by how gory this is, but the orthopedic surgeons often fillet open that finger all the way down the length, and they kind of explore, and it's really sort of a gruesome affair. Okay, so we're moving out of infections and into some traumatic injuries, and the first of these is the boxer's fracture. And so this refers to a fracture of the neck of any of the metacarpals, though we really think of this as a lot with the small finger. And it's rather a misnomer, because boxers, those who are truly trained in how to throw a punch, are not going to have this kind of injury. This is more of an amateur boxer's fracture, like an England fan whose team just lost, the Euro Cup finals, who punched a wall. That's the person who's going to come in and with this sort of injury. There's two things you really need to think about that you cannot miss with these injuries, and one is remember those extensor tendons are really superficial. So be sure that when they have an injury to the bone, they don't also concurrently have an extensor tendon injury. And the second is doing a really good skin exam. If they did make contact with human mouth, making sure there's no break in skin that would suggest a fight bite that would be prone to infection. When you're looking at the x-ray, you can see that this fracture is kind of angulated right here, and we do accept some amount of angulation. In the small finger, we can accept up to 40 degrees of angulation. In the ring finger, 30 degrees, middle finger, 20 degrees, and index finger, 10 degrees. So some degree of angulation is okay. If it's really angulated, I'll usually reduce it in the ED. The one thing that is not acceptable is malrotation. And what does that mean? And how do we examine that? So if you take your hands and you sort of fold your fingers into your palm, you can see that all four of the fingers are kind of in parallel, pointing to the scaphoid. They're pointing to your to this thenar eminence, and they're in parallel. So if instead, when you're doing this, the pinky is sort of sticking out straight, not the pinky, the small finger is sort of sticking out straight or folding over or tucking under the rest of the fingers, then that's suggestive of malrotation. Or if you look dead on at your nails, you can see they're kind of all in the same plane in their orientation, and if one is really wonky, then again that suggests a malrotation, and those will actually have to be pulled upon and manipulated by the orthopedic surgeon as an outpatient. Metacarpal fractures that are not involving the neck, kind of similar principle. Look for malrotation, an acceptable degree of angulation. For the most part, these are going to be splinted and go out and see an orthopedic surgeon. So now we're going to talk about the Boutonniere's deformity, and this is more proximal than that SWAT neck deformity we talked about. So the extensor tendon, now we're talking about the extensor tendon, runs down the finger, and right when it gets to the PIP, it splits into three parts. There's the central slip of the tendon, and that holds the PIP in extension, and then there's two lateral bands on the side that hold the DIP in extension. So if you have a blunt or penetrating injury to that dorsal aspect of the PIP, the central slip can be injured. And what happens, a boutonniere is a buttonhole. What happens is the PIP sort of pops up through the lateral bands. It's no longer held down by the central slip like a button coming out of a buttonhole, and they can get this deformity where the PIP is held in flexion. So be really cautious with injuries to the extensor side of the PIP and make sure that they don't have a central slip injury, because this deformity can occur. We'll talk about proximal thumb fractures. Thumb fractures obviously are devastating because we need our thumb for everything, but they're also rare because the thumb metacarpal has a lot of range of motion. If it is injured, we're going to talk about specifically about fractures to the base of the metacarpal that are intra-articular. There's two main flavors, the Rolando's fracture and the Bennett's fracture. One is worse than the other. I remember it because Bennett is benign, Bennett benign. They sound kind of similar. Regardless, if you have one of these fractures, they're going to go in a thumb spica splint, and they're going to go to an orthopedic surgeon, most likely for operative repair. If someone has thumb pain, but they have a negative x-ray, this is one of the diagnoses to consider, and this is an injury to the ulnar collateral ligament. So on the ulnar side of the thumb MCP is a ligament called the ulnar collateral ligament. And if you're skiing, for example, and all of a sudden your pole gets caught and there's a lot of radial deviation of the thumb, you can snap and injure that ulnar collateral ligament. That's a skier's thumb. That's an acute injury. A gamekeeper's thumb refers to more of a chronic repetitive injury. Back in the day, gamesmen would break the necks of small game like rabbits, and they do this over and over and over and over again, and then eventually they would cause damage to the UCL. So that's a chronic injury. Regardless, they both cause damage to the UCL, and the way you check this on exam is you sort of stabilize the thumb MCP with one finger and then radially deviate and pull that thumb away from the rest of the fingers, both an extension and a little bit of flexion, and you assess for laxity. And again, like I mentioned, I'm no pro at laxity, and a lot of people have fairly lax fingers, so check the unaffected side first before you check this affected side. And if you do see this injury, then they're going to need to go in a thumb spica and potentially might need operative care if the ligament is fully injured. Carpal tunnel syndrome, we see it a lot. It's not really an ER diagnosis. Usually patients will complain of pain and numbness and paresthesias in sort of that median nerve distribution, and they usually complain of symptoms that are worse at night. And I always wondered, why is it that the symptoms are worse at night? The anatomy is not changing overnight. And what's happening, I see someone doing this, is that during the day you can kind of keep your hands in sort of a neutral position. You're not exacerbating the compression of the nerve. But at night, you're sleeping like this or like this or like this, and that's going to worsen your symptoms because you're going to cause worsening compression of the median nerve. So diagnosis is really clinical. You can do some exam maneuvers. You can tap over the median nerve. You can hold the wrist in flexion for about 60 seconds and see if that elicits the pain and reproduces the pain. But really, this is a clinical diagnosis and should hopefully get better with NSAIDs plus or minus splinting. And worst case scenario, they can have a tunnel release done by an orthopedic surgeon, but obviously not in the ED. So we're going to move into wrist injuries, and I just want to put a little word of caution that I do almost anything possible to avoid making the diagnosis of wrist sprain. And if I do, there's a certain set of diagnoses I'm running through to make sure I'm not missing wrist sprain mimics. I think of this as somewhat similar to diagnosing someone with abdominal pain with gastroenteritis. I really try not to do that as well. So let's go through some of these wrist sprain mimics. And one of these is the scaphoid fracture. I think we're probably all attuned to looking for this. And why is it that this is a can't miss fracture? It's because the blood supply to the scaphoid is somewhat unique. It comes up, it enters the distal part of the scaphoid first, and then goes to the proximal part. So if you have a fracture across the waist of the scaphoid, that distal part's still going to get blood. It's going to be fine. But that proximal part could lose blood supply and undergo avascular necrosis and cause chronic pain. So we don't want to miss these fractures. The problem is about 20% of the patients that come in with this fracture are going to have a normal x-ray. So how are you going to pick up this diagnosis? You're going to do a couple physical exam maneuvers. The first is you're going to check for tenderness over the snuff box, but you're going to do this in ulnar deviation because that helps to make the scaphoid a little bit more apparent. You're then going to do axial loading of the thumb, and you're basically jamming the thumb into that fractured scaphoid, so that should cause tenderness. And then you're going to turn your hand over the palmar side, and you're going to feel for the scaphoid tubercle here on this side, and feel for tenderness at the scaphoid tubercle. I'm going to add two more to that list. One is resisted supination. So if I hold here at the forearm and I ask them to supinate and that causes pain, then that's concerning. And the most concerning one to me is if I ask someone, hey, where's your pain located? And they come at that thumb in this clamp sign and they say, this is where my pain is, and they demonstrate this with a clamp sign, then that also is very concerning for a scaphoid injury. So if you suspect this, we're probably going to immobilize the patient in thumb spica splint, send them out to be seen by a PMD orthopedic surgeon in 1 to 2 weeks for a reevaluation and potentially advanced imaging, knowing that only one of these four is probably going to have a fracture, but it's really just too important to miss. So here's an example of what a fractured scaphoid would look like, but just remember a lot of them are going to come in with an x-ray that looks like this. Scapholunate dissociation is another diagnosis to consider in terms of a wrist sprain mimic, and this is a ligamentous injury. It's the most common ligamentous injury of the wrist, and if you miss it, patients develop terrible chronic arthritis. So again, one we can't miss. On x-ray, you may see this gap between the scaphoid and the lunate because of damage to the ligament. It's likened to what it looks like when someone has a gap between their front teeth, like David Letterman or Michael Strahan. And so if you see this gap, that's great. That's going to give you your diagnosis. If you don't see it and you suspect this diagnosis, you're going to need to get a clenched fist view, and as the person clenches their fist, that actually puts a little bit of pressure on that joint and can make the widening more apparent. One physical exam maneuver that might suggest that you have this injury is I want everyone to take their wrist again and feel your radial styloid and then move over ulnar in the ulnar direction until the very next prominence you feel. And that is your Lister's tubercle, and then slide a little bit distal until the next pocket you kind of fall into a divot. And if you feel tenderness there, then that's concerning for a scapholunate injury. The last one I'm going to put on your radar for wrist sprain mimics is the lunate and the perilunate dislocations. And when I'm looking at a lateral x-ray of the wrist, there's not a whole lot I'm looking for. I'm not that great at looking at x-rays, but this is on the top of my list. I want to see that the radius is sitting right underneath the lunate, the moon-shaped lunate, which is sitting right underneath the capitate, the cup of the capitate. I want to see all those three bones aligned. So if you look at this x-ray on the right and you see here that half moon, the lunate, has fallen off, this is a lunate dislocation. And if you look at this x-ray here, the half moon's still fine, but the cup has fallen off, then unfortunately this is not a capitate dislocation because that would just make too much sense. This is called a perilunate dislocation. Regardless, these are both emergencies. These need to be reduced in the ED. They can't be splinted and sent out, and you have to be really cautious about doing a median nerve exam because that can be caught during these dislocations. And this is again an illustration of where a Lister's tubercle is. As we're wrapping up, I want to talk about splinting of the hand and the wrist, and you can do a really good job making a great diagnosis, but if you don't do a good job with splinting, you can actually make the patient worse. So one thing is you can cause stiffness, as we mentioned with a neomobilizer. You can cause atrophy of the surrounding muscles, and you can actually take a non-operative fracture or non-operative injury and make it operative. So put a lot of thought when you're splinting patients. One thing that they mentioned is splinting patients in a position of function, and that's kind of the same way you think about if you were holding a beer or a soda can. The wrist is slightly in extension and the rest of the fingers are slightly flexed. But you can always refer to this diagram, but just make sure you're approaching the splinting with a lot of caution. The last thing we're going to finish with is digital nerve blocks. These are really fun. They're so effective when we're going to use them when we're dealing with the felon or lacerations of the finger. And there's two main approaches. There's a classic dorsal approach and there's a volar approach. And so in the dorsal approach, remember the digital nerves run on the radial and ulnar side of the finger. So you're sort of going in one side of the finger at the base and dumping in some anesthetic, and then going in the other side of the finger at the base, dumping in some anesthetic, and then you go chart and come back and the finger's numb. I have become a convert to this approach. I've been doing this for the past 8 years or so, and the reason I like it is because nobody likes you to come at their hand with a needle, and this involves just one injection. So instead, you're going to come from the palmar side, and you're going to inject either at the palmar crease, or what I do is inject more distally, right where the fingers meet the palm. And you're going to go down into hit the flexor tendon, you're going to dump some anesthetic in there, and then because of that flexor tendon sheath, the anesthetic can sort of run all the way distally to the finger and sort of fall over the finger and bathe those digital nerves. And I find this very effective, and it's a single poke only. There's two other approaches. The web space injection, that one looks terrible to me, and a direct digital injection. I don't think you need to know either of those because both the dorsal and the palmar approach work quite well. A couple tips about digital nerve blocks. Try not to go through infected skin. So if you see an area of erythema, that might push you more towards a palmar or dorsal approach. And then, as mentioned before, you want to use a small gauge needle, and you want to avoid this tendency to seesaw and, oh, am I in the right place? Am I in the right place? And go back and forth because you can definitely do damage to the nerve. But really, these are quite effective. They work quite well, and they're fun to do. So get practice at it, and try a different approach if you haven't done that already. So that is the hand, and that wraps up all of these orthopedic injuries, and I hope you feel more empowered to do a good exam and think of your differential. And I just want to say thank you to everybody. I've only been here today, but it's been so fun to get to know some of you, and thank you for having me.
All right, so this is our last substantive lecture, neuropsychiatric disorders. It's a little bit of a grab bag lecture, not any consistent story or theme to this, so we're just gonna go through this. It's gonna be a faster lecture than we're accustomed to, but we're just gonna use it as a chance to wrap up, answer any questions, and then I believe that Martha comes us up for the last lecture. So we were familiar with our brain anatomy. A slide here to remind us of our muscle stretch reflexes, useful to review. From a clinical standpoint, always important to remember that the anal sphincteric reflex is higher than the innervation of the lower extremities. Dermatome man, always a reassuring and refreshing picture. There's barely a time that goes by when I'm not evaluating a patient with shingles where I don't turn to dermatome man to have a better insight into which dermatome we're referencing. If you're not familiar with dermatome man, this is simply a pictographic representation of the neurologic sensory innervation of the body, always useful for diagnosing levels of neurologic deficit, so a spinal cord injury, or for diagnosing patients with shingles infections as well. The dermatomes have a number of ways that you can easily remember them. I have a habit of remembering the umbilicus as T10. To be honest with you, I don't remember any of these other ones and can always look it up when it becomes apparent. The Glasgow Coma scale, I do want to spend a few moments on. The Glasgow Coma scale, most people are familiar with. I remember learning the Glasgow Coma scale as an early EMT some 20 years ago. And there are a lot of myths and misinformation surrounding the Glasgow Coma scale. Things like GCS of 8 means we should intubate, a moniker that has served a lot of people well, but has over the past several years been recognized to probably be a poor approach to patients presenting with deteriorated mental status. The Glasgow Coma scale has relatively poor inter-observer reliability and relatively poor prognostication in any one way, shape, or form, and probably shouldn't be used as a fiat determinant of anything that we're doing in the medical care space. A couple things about the Glasgow Coma scale. Remember, you can't have a score lower than 3. A GCS of 3 is the lowest. It's a dead person. Somebody who's flaccid, has no verbal or eye response would have a GCS of 3. Not a month goes by where I don't get a report of a GCS of 0, and you know that patient's really ill. Reminder that a patient who's intubated is a GCS of 3T, with the T designating that they are intubated. Mental status exams, just a reminder for the mental status exam that it is important for us to go through the entire OMI hat mnemonic, understanding orientation, memory, intellect, hallucinations, affect, and thought. Every single one of these helps contribute to the overall mental status of a patient. And having a more complex evaluation of a patient's decision-making capability always will dial you into a little bit more information about their neurologic or psychiatric status. A common question that we like to ask, you're walking down the street, you see a letter on the ground next to a mailbox, what do you do with it? The patient's accurate answer should be that they pick up the letter and place it in the mailbox or something to that effect. Any interruption that could signify some interruption in their cognitive capacity. It could also signify that they're just an idiot. The cranial nerves. So when we evaluate our cranial nerves, we have our standard evaluation. We're all familiar that cranial nerves 2 through 12 are repeatedly grossly evaluated, but our neurologic exam often suffers in the evaluation of the cerebellar aspect of the brain. And we have so many warnings that we've heard in so many lectures throughout this course that ambulating your patient is a rock solid and medical legally advisable intervention. Gait normal gait is in itself a fantastic evaluation of the cerebellar exam. Adding on to it the Romberg test, as well as coordination, looking for dysdiadochokinesia or dysmetria, every single one of these things will dial you into a more thorough physical exam. So just a reminder from that slide to incorporate the cerebellar exam and document it thoroughly in your neurologic exam. The approach for a patient with altered mental status, many people may remember the mnemonic AEIOU tips. Parsed out here, the number of different things that can contribute to altered mental status. I always see stroke on here and always have difficulty with placing stroke into the category of things that can cause altered mental status. But of course, a patient presenting with a large area MCA distribution stroke or hemorrhagic stroke can certainly present with altered mental status. And when a patient presents with altered mental status, we often are sort of set with either immediately knowing what's wrong with the patient because it's apparent, or having to fire off the shotgun of tests to approach these. And so our altered mental status approach is very frequently one that includes a large amount of testing. Patients having a CMP, tox screens, looking for acetaminophen and aspirin levels, blood alcohol levels, so many of these things which we discuss, but so often we find that they are relatively of little value. But why do we want to highlight these, and why do we want to bring it up? Because, as Dr. Bucata said, as we've all said, if you don't think about it, you don't think about it. And it's always good in the setting of patients with undifferentiated altered mental status to run through that differential diagnosis, however sort of out there it may be. Consider, for example, ammonia levels. Not a routine test that we send on many patients. We think of ammonia certainly in patients with history of hepatic failure, patients with cirrhosis, patients with advanced liver disease, and understanding that ammonia and elevated ammonia can certainly be coordinated with hepatic encephalopathy. But we also have to recognize a few more things about ammonia. For example, you don't need any elevation in your ammonia whatsoever for the diagnosis of hepatic encephalopathy. That's called minimal hepatic encephalopathy, and it's a real diagnosis that we encounter on a regular basis. By the same token, the elevation of your ammonia does not correlate with the severity of your hepatic encephalopathy. And so the pooling of an ammonia level is often of little value in the emergency department. When might it be of value? Certainly if the patient's altered mental status is undifferentiated, and an elevated ammonia level may be of significant finding and help drive you down to a diagnosis of hepatic encephalopathy. But I want to highlight one more case, one more type of elevation of ammonia that's perhaps unrecognized, underutilized, and I want you to think about patients who have had previous gastric bypass surgery. Patients with previous gastric bypass surgery are an under-recognized component of patients who will present to the emergency department with elevated ammonia levels, and recognition of it early on can be life-saving for these patients. Treatment of patients who are, and then lumbar puncture. We spoke yesterday about my love of the lumbar puncture. Remember that lumbar puncture is an incredibly important and valuable diagnostic tool in many different patients, and the patient presenting with altered mental status, particularly presenting with any other signs of infection, for example, fever or headache, the application of a lumbar puncture can be extremely diagnostic. Treatment, the treatment's pretty straightforward, A, B, C, D, antibiotics if they need them, but I want to talk a little bit about the Coma cocktail. Many people may have grown up on the Coma cocktail. Patients come in, we give them the naloxone, thiamine. Once upon a day, we gave them flumazenil. We consider giving them glucose, all these different things which we can empirically throw at a patient. And many of us have learned over time that in a patient with alcoholic malnutrition, the application of thiamine prior to dextrose is important to avoid the precipitation of Wernicke-Korsakoff syndrome. There is a lure out there that the application of dextrose prior to thiamine may upregulate metabolic processes and lead to Korsakoff syndrome in patients with alcoholic malnutrition. It is on the level of case reports that this has been created. If you hearken back to the very basic literature basis that drives the concern for Wernicke-Korsakoff syndrome in patients receiving dextrose prior to thiamine, it comes from the Irish Journal of Clinical Medicine around the turn of the century, around 1902, when a total of three patients developed Wernicke-Korsakoff syndrome after being treated with dextrose at some point in time. It wasn't immediate. Some patients had this weeks later. And looking back at those case studies, one can see that there's a very loose association, if any, between the delivery of dextrose and the development of Wernicke-Korsakoff syndrome. But let's just sort of stay on this path for a little bit longer if we can. Alcohol use disorder is a significant insult to the United States GDP. It costs us about $100 billion per year in total direct and indirect costs, patients suffering from alcohol use disorder. And these patients present to the emergency department routinely. We see this all the time. And there's a lot of rampantly underdiagnosed pathology in this population that I promise you have seen. It has seen you, and you've done nothing about it. I've done nothing about it, and we should do more about it. So let's talk a little bit about thiamine supplementation in the patient with chronic underlying alcoholic malnutrition. Has anybody ever seen a patient come into your emergency department drunk and malnourished? And yeah, this is very, very common. And we should be supplementing these patients with thiamine. The addition of thiamine to these patients does a lot of good. And what we now know is that there's an unrecognized phenomenon of thiamine deficiency in patients with chronic alcoholic malnutrition in the United States. And that's one of the big contributors to that $100 billion insult to the GDP each year. So what can we do? Well, we know that thiamine supplementation in the truly malnourished patient should really be parenteral if at all possible. And the delivery of parenteral thiamine in the emergency department followed by a prescription for oral thiamine supplementation isn't sexy. Right? You're not cracking open a chest with a prescription for thiamine, right? It's a vitamin. But what we do know is that it can have a profound effect on our healthcare infrastructure. Hundreds of billions of dollars per year that get pulled back into the economy because we can get ahead of alcoholic malnutrition and thiamine deficiency. And you have seen this. Patients who roll out of the emergency department in the morning and they have a little bit of an unsteady gait as they walk out of the emergency department, and we all chuckle to ourselves, haha, he's still drunk. No, he has alcoholic polyneuropathy. He has dry beriberi. He has thiamine deficiency. And we can get ahead of these in our patients. And you know who these patients are, and you know how you can help them. Really, I want you to consider the use of thiamine in your daily practice for patients with chronic alcoholic malnutrition. Bacterial meningitis, we had a fantastic talk on this by Dr. Bucata, which really talked about the sort of changing epidemiology of bacterial meningitis in the United States. But it still is an important diagnosis for us to make in the emergency department. And while it's true that most emergency departments on average will see less than one case per year, the odds are that the larger centers are going to see more of these cases and the smaller centers will see none of these cases, correct? The averaging simply sends it the other way. The diagnosis of bacterial meningitis is one that's made by, again, lumbar puncture. A few tips when we talk about the diagnosis of bacterial meningitis. Once upon a time, we were told that we needed a head CT prior to lumbar puncture in patients with bacterial meningitis. It's not true, right? You only need that head CT if a patient has alteration in their mental status or neurologic deficits. Additionally, this is a place where we talked about before, fundoscopic exam can be important. A fundoscopic exam with any evidence of elevated intracranial pressure would be a sign that a patient should undergo CT prior to lumbar puncture in the setting of concern for bacterial meningitis. Let's move a little bit further down the road in bacterial meningitis. Where are we at in the world, and where might we be going in the world of bacterial meningitis? We know that the most common causes of bacterial meningitis, pneumococcus, meningococcus, have really decreased over the past several years, of course, because of vaccine interventions. But we are seeing other causes of meningitis that are continuing to rise, and we're continuing to see pneumococcal, meningococcal meningitis at rates that are simply far too high because this is life-threatening. This kills people. There's some really exciting stuff out there that I think is going to be a whole new step forward in our diagnosis of these rare diseases, including epidemiological modeling as well as an enhanced ability in the United States for us to monitor our sewage system for these pathogens. And as we begin to be able to identify these pathogens in our area, we are 5 to 10 years away from you getting an alert in your ED. Hey, Neisseria meningitis has been detected in our area. You need to have a higher suspicion for meningococcal meningitis for the next several weeks. That's where we're at, and that's where we're going. We're only going to get better at this diagnosis. We already do a really good job, and it's an exciting future ahead of us. We've talked about bacterial meningitis and the distribution. I do want to remind you, don't delay the administration of antibiotics. They do not sterilize the CSF that quickly. You can still get a needle in the spine. A little bit of tip for doing your lumbar puncture. Everybody's done a lumbar puncture needle into the spine, right? How many of you sit there and do this ridiculous thing where you keep pulling out the stylet and checking to see if you got in there? You don't need to do that. Why does the stylet exist? The stylet exists because if you transport that skin to the spinal cord, you can develop an epidermoid cyst, right? That's why that stylet is there. So as soon as you're through the skin, you can go ahead and take that stylet out. It's not doing anything more for you, and that way you're not sort of checking, kind of that ridiculous repeated check of the lumbar puncture needle to see if you've made it in the space. Take that stylet out, get into the space, get your fluid, put it back in before you remove so you avoid a suction phenomenon, but a nice little tip for lumbar puncture performance there. Meningitis treatment, of course, in neonates, we use ampicillin plus cefotax, and we don't typically upgrade to the use of ceftriaxone until 3 months. The reason for that is that ceftriaxone can displace bilirubin off of albumin and lead to hyperbilirubinemia in this setting. So remember the use of cefotaxime in lieu of ceftriaxone prior to 3 months. Once you hit 3 months, high-dose ceftriaxone is the treatment of choice for most patients presenting with bacterial meningitis. The role of steroids is controversial and very interesting. There is some literature to suggest that steroids in first world countries can decrease the neurologic complications associated with antibiotic treatment of pneumococcal meningitis. And that's interesting and that's helpful, but that same literature suggests that that benefit is not recognized in third world communities and it's not recognized in certain subpopulations. What's more, we know that steroids can increase mortality in certain types of meningitis. When we look at, for example, tubercular meningitis versus cryptococcal meningitis, steroids have different impact on mortality in those scenarios. So the introduction of steroids into your treatment algorithm for meningitis may be something that you want to have a conversation with the admitting physician for. While it may decrease the neurologic compromise associated with some causes of meningitis, it may actually increase the morbidity and mortality associated with other types of meningitis. And it's something to drill down on, get some more information on, and have an informed conversation with your admitting team about. I want to talk about seizures. I hate seizures. Seizures I've always found a relatively difficult clinical condition to encounter because it certainly runs the gamut from patients who are presenting with benign primary seizure disorder to patients who are presenting with very serious underlying disease. And our evaluation of the etiology of seizure always needs to begin with, do they have epilepsy? Do they have an underlying seizure disorder? But are there metabolic, structural, traumatic, or toxic causes for this patient to be presenting now with a seizure? Do they have preeclampsia? Do they have a mass in the brain? Are they incredibly ill, and that's why they're presenting with seizure? We in emergency medicine have begun to use surrogate markers to help us make this diagnosis and distinguish it when it's difficult to distinguish, for example, from syncope or a patient acting a fool, right? We look for a patient to have an elevated CK or an elevated lactate, and we use that as a little bit of a surrogate to help support our diagnosis of seizure. Interestingly, a few years ago, there was a lot of talk about the use of prolactin for the diagnosis of seizure. And there's some evidence that prolactin levels are elevated for the first 20 minutes following a seizure, and that they're quite specific for the diagnosis of seizure if you're having difficulty parsing the difference between, for example, psychogenic non-epileptiform activity to seizure disorder. Consider a prolactin, a lactate, or a CPK. All of these can help build your diagnostic sort of armamentarium and have a clearer insight into what's going on with a patient. When patients come in and they have a new onset seizure, it's kind of a bigger workup, right? These patients are going to get CT'd. A full workup would include a sort of infectious search as well. Routine lumbar puncture not typically warranted in patients presenting with first-time seizure, except in those situations when you're concerned for an underlying infectious etiology of their seizure. Certainly in the pediatric population, pediatric patients presenting at less than 1 year old with a new onset seizure, there should be a relatively low threshold for lumbar puncture in those individuals. However, in patients who present with a history of seizures and they present with a breakthrough seizure, there's a relatively low level of intervention that's required. Certainly, repeat imaging of the brain should only be undertaken in a patient with new deficits or new features to their seizure disorder, but even additional lab work, including checking electrolytes, checking glucose, checking troponin, checking whatever you want to check, the data again and again and again has shown that this is a low value proposition. That patients who have seizure disorders and have seizures, the diagnosis is seizure, and they have seizures, and they have a seizure disorder, and they should talk to the neurologist about new medications. So let's talk a little bit about new medications. When a patient presents to the emergency department with a seizure, the treatment is straightforward. It's benzos, 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 other stuff. Give benzos, give more benzos, don't be shy with your benzos. Recent publication about 2 years ago comparing all the different benzos, diazepam versus midazolam versus lorazepam, found that they all act relatively similarly and all have sort of their pluses and minuses for intervention. They all terminate seizures with the same success, but what do we have? For some medications, for example, midazolam has a easy access for intramuscular administration and can abort seizures quite quickly there. The Rampart trial, for example, informed us that in patients without without any peripheral intravenous access, the administration of intramuscular midazolam may be a better tactic to take than starting an IV and administering intravenous lorazepam. Of course, if a patient already has an IV, a typical approach is to administer 2 to 4 milligrams of intravenous lorazepam to terminate the seizure. Other options include diazepam, which has an active metabolite, nordiazepam, which may be helpful in keeping seizure activity at bay at prolonged time frames. And so what do we know? That about 90% of seizures will terminate with benzodiazepine therapy, but there is a component of patients who will need additional therapy beyond benzodiazepines. These are patients who do very well, typically with the administration of levetiracetam or Keppra. Then there's some guidelines that are all over the map on this. Some people talk about 20 mg per kg, all the way up to 60 mg per kg of loading doses for patients with refractory status epilepticus, and it should be a pathway that you've worked out in your emergency department with your neurology colleagues. Phenytoin and phosphenotoin, of course, have been used for many years as a second-line treatment for status epilepticus, and phenobarbital, Depakote, and all the other choices remain there as well. But let's talk a little bit about Depakote because we talk a little bit about underlying seizure control. A patient presents to the emergency department and has a first-time seizure. Guidelines tell us that unless that patient has a high risk of seizure recurrence, they generally should not be started on anti-epileptic medications following their first-time seizure. But other patients, some patients may initially be started on anti-epileptic drugs, and then other patients certainly are going to be started on anti-epileptics, either by yourself following a second, third, fourth-time seizure, or by neurologists in the outpatient environment. And there's a long list of stuff they can be on. It only seems to grow by the day. But we need to become familiar, at least, with the ups and downs of some of those medications and how we can intervene and save a life. Can you level any of these medicines? Of course, right? We classically talk about leveling phenytoin. We talk about leveling Depakote, about leveling other medications like phenobarbital. But you can level any of these medications that you want. But we need to know about the ones that can cause true harm if they're toxic, right? Patients who present with elevated levels of valproic acid and have Depakote toxicity, or patients who present with elevated levels of phenobarbital and are comatose. These things are important. I want to talk a little bit about Depakote or valproic acid because, as you may have seen, we've seen a move away in some populations away from valproic acid into some of our newer medications like Vimpat or levetiracetam, medications which are once or twice daily dosing and don't require therapeutic drug monitoring. The reason for that is valproic acid actually induces its own metabolism over time. And so patients who are on Depakote for a longer amount of time may have progressively decreased efficacy of that medication as it begins to upregulate its own metabolism within the body. So a little pearl to keep out, in fact, especially when you see patients who are still on valproic acid, consider leveling that medication. If you find that it's low and the patient swears up and down that they're being consistent with their medication, they may have begun to auto-metabolize that medication, and it's time to switch over to a new one. We're going to talk a little bit about functional disorders versus organic disorders. And in the emergency department, we have a growing task upon us to serve almost as emergency psychiatrists. And Dr. Bukata had an important story of a physician who was delivering ketamine for depression and suicidality in his emergency department. And I have a lot to say about that, and it's very interesting. Ketamine has been very well demonstrated to decrease symptoms of major depressive disorder, as well as independently decrease the risk of suicide in patients with major depressive disorder. And it is, I think, down the road, likely to be a medication that we see administered from the emergency department to temporize suicidality in the future. I want you to slowly become familiar with that, but more importantly, I want you to begin to embrace our role as clinicians that address patients with acute psychiatric emergencies as much as we address patients with non-psychiatric emergencies as well. And these can be extremely difficult. Functional disorders can range all the way from birth to death, but classically between 15 and 40 years of age and are gradual in onset. These patients, different. And these patients can have a number of different complaints. They can have underlying antisocial personality disorders or other underlying psychiatric comorbidities. And every single one of these can make the presentation and the experience in the emergency department more difficult for both patient and provider. And it's incumbent upon us to recognize the underlying personality disorders, which will drive a more difficult clinical encounter, but help us understand how to intervene upon them. As we talked about therapeutic drug monitoring levels And as we move a little bit into these underlying psychiatric disorders, I want to pause really briefly on patients with bipolar disorder, something that we see less of as we see more and more second, third, and fourth generation antipsychotics come onto the market is less use of lithium. But lithium toxicity continues to be a consideration in the emergency department. Lithium toxicity is easy to find its way into, either acute or chronic lithium toxicity, and can lead to really serious outcomes, including neurologic compromise, ataxia, altered mental status, and even death. Think of things like silent syndromes, or syndromes of ongoing lithium toxicity that lead to real true morbidity down the road. Some signs of lithium toxicity, of course, the clinical. A patient will present and they're off, classically and commonly with GI symptoms, but ataxia and odd neurologic movements are often found in patients with lithium toxicity. But lithium toxicity also induces diabetes insipidus, and nephrogenic diabetes insipidus. And a good sign, a little pearl, keep an eye out for diabetes insipidus, is lithium overdose in diabetes insipidus is one of the few things that can cause a zero or a negative anion gap, because you have unmeasured cations, and it's one of the few times, along with monoclonal gammopathies and multiple myeloma, where you will see a negative or zero anion gap. If you see that, I really want you to think about lithium toxicity, diabetes insipidus, multiple myeloma, monoclonal gammopathy. And so schizophrenia we'll pause one more time on, because schizophrenia is of rising incidence in the United States. And patients with schizophrenia have poor health outcomes from the emergency medicine sphere as well as the primary sphere as well. An average age of onset of 15 to 35 years, some scholars believe that there's a shift in the age of onset of schizophrenia because of increasing uses of cannabinoids and cannabis in the United States. And as we see legalization of cannabis on the state level and considerations on the federal level, we have some literature to suggest that patients who have underlying schizophrenic disease may manifest their symptoms of schizophrenia early if they engage in cannabis use. And so we've seen a shift of the average age of onset of schizophrenia in the United States, and there's at least some postulation that that may be related to increased cannabis use and breakthrough of schizophrenic symptoms earlier in life. Depression, of course, we see on a regular basis, but let's talk about suicide because it's a disaster. Physicians and nurse practitioners and physician assistants are dying all over the country at rates that have outstripped anything in history. And while suicide in patients who present to our emergency department are very important things for us to intervene upon, it's just as important, if not more, for us to recognize symptoms of depression and suicidality among our colleagues. We don't talk about that enough. It's stigmatized all too much. Keep an eye out for each other. Somatoform disorders can be extremely difficult. Patients who present with Morgellons disease or other sort of manifestation of visceral or neurogenic symptoms as somatoform disorders. These can be as simple as hypochondriasis all the way progressing to conversion reactions or worse, and these can be extremely difficult to encounter in the emergency department, but it is not our task necessarily to identify the subgroup of functional disorder that a patient is presenting with. Our task is to exclude those organic and life-threatening disorders that a patient may actually have. And so let's finish this up with a talk about delirium and dementia. Let's talk a little bit about that. We're all familiar with this, right? Delirium, oscillating mental status, the severity fluctuates, it eventually will end. The patients are confused. We hear any sort of moniker for this, ranging from sundowning to whatever. And this is clearly different from dementia, which is gradual in onset, consistent, definitely doesn't have those oscillating periods, but is very difficult at times to parse out in an elderly patient population. And so we need to do a better job at identifying delirium. And in particular, we need to do a better job at identifying hypoactive delirium. Now, I want to bring this up, and it's going to seem like a little bit of a departure from what we've been talking about, because we're going to come off of the functional disorders, and we're going to talk a little bit about about organic disease for just a minute. We see patients with hypoactive delirium every single day, and we miss it every single day. Think, if you will, of the nonverbal elderly patient who presents to the emergency department not acting right or with altered mental status. It's an 87-year-old female, trached, pegged from a long-term care facility, nonverbal, had a previous stroke. She's not feeling well. She's just not acting right per the nursing facility. You do a big workup. What do you find? The urine is dirty, because the urine's always dirty in patients who are in long-term care facilities. The data is clear. The patient does not have a urinary tract tract infection, the data is clear that so many of these patients who present to the emergency department as simply not acting right, and we call it a UTI because there's always a dirty urine, are actually hypoactive delirium, a markedly underdiagnosed condition in the elderly population, and one that we need to do a better job of recognizing. So the next time you have one of these patients, and I know you know who these patients are, I want you to think about hypoactive delirium. And the causes of hypoactive delirium are many. They can be as simple and difficult to intervene upon as the environmental surroundings, right? You don't get enough sleep, you're at a long-term care facility or a skilled nursing facility and you can't get to sleep, and that can lead to delirium. But more often, what is the true cause of this? It's polypharmacy and medications underlying in the elderly population. And you can do a lot of good about really just giving a glance to that med list, looking for anticholinergics or any other medications which may cause alteration in sensorium, and you can do a lot of good instead of just calling yet another patient, yet another urinary tract infection, and admitting them yet again for yet more unnecessary antibiotics. And then, of course, there's malingering, Munchausen syndromes. Those presentations were extremely difficult to present in the emergency department, and I don't have too much advice for you on those, except to say that in the end, all we can offer in these syndromes and symptoms, when we don't have medical facts to offer and we have no medical interventions to pursue, is very simply to have that compassion and understand that patients with these underlying somatoform or with neuropsychogenic disorders are not trying to jam up your day, they're not trying to jam up your day, have true underlying comorbid disease, which more often than not, we're not set out to care for, and specialist consultation is needed right away. So that's a bit of a grab bag when it comes to neuropsychiatric disorders, and is the conclusion of our course before the wonderful Martha Roberts will come and send you on your way. Again, I'm Rick Pestor. It's been a true pleasure, and thank you very much.
Thank you, Rick. Okay. So this is the last lecture. We wanted to move it, of course, to actually the last lecture. And this is a collection. It's a quick talk to end the course, and essentially it is odds and ends, right? So a lot of things we see in the ER are odd, and most days we can't wait for our shift to end. So I'm going to go through just a couple of key things that we spoke about during the course, that we all spoke about during the course, that we'd really like to drive home, and then leave you with some discharge information, some smart phrases, some of the things we promised we would give you to say, okay, I've learned all these things from this book and from this course, and now I need to send the patient home. How do I put it all together? Well, one thing is, when you're on shift, if you want to use the book, certainly you can rip out a couple pages and keep them in the book that you've already made with your information. But a couple of things might run through your mind. Hey, like, I remember they said this. I can't quite remember that graph, or I can't remember that fracture, or what this looked like. Flip to that section, and then you'll go, oh, I remember that. And that has helped me when I've gone back into practice. So discharge paperwork, when we get to that towards the end here, you know, writing things like never drink like that again might seem funny at the time, but maybe instead of saying something like that, I'm always really a big component of being super compassionate with patients. You know, when I see things like this, okay, yeah, I mean, could have avoided that visit to the ER, but maybe give them some actual helpful, useful things for them to do. And you have social workers and people in your department to help you with this, so utilize them. So let's just remember the top 10 reasons why people go to the emergency department in the first place, right? So we've learned all about these things during the course, from abdominal pain, chest pain, fever, cough, headache, vomiting, accidental trauma, dyspnea, pain, chronic pain, any kind of pain, and back pain, which is its own separate entity, of course. And sometimes patients will come in with all 10 of these things, and you're like, well, you get one complaint today, one chief complaint. So just be familiar with these top 10 things, and you're going to do about 85% of your care work based on this, 85 to 90%. But what are the top 10 causes of death? Why are our patients dying? Now, I don't want to take any conversation towards the C word, COVID here, but about 74%, 3/4 of the stuff that comes into the emergency department that causes death really hasn't changed over the last 10 years. And if you look at the CDC website and the statistics on this, heart disease is still #1. So if you're really good at knowing heart disease and the presentation of heart disease and MI and all these other things associated with that, you're going to do a really good job. Cancer, if you're really familiar with treating those sick cancer patients that come for their acute emergencies, you're going to do a really good job. So on and so forth through all of this. And as Pescatore had mentioned suicide is up there on the top 10 cause of death, so that is something certainly that we all need to be aware of. What are other days of the week that are deadly days to live? Well, this is an interesting study brought out by the Center for Disease Control, the CDC, and essentially, don't leave your house on a Saturday, okay? Saturday, people are dying in car accidents, they're dying of drug overdoses, possibly drug overdoses that lead to car accidents. They're also dying of other accidental traumas in general. Sunday is the day that is most popular for firearm injuries. Monday is the day that most people are gonna have their heart attack. Anybody see that commercial that's like, Bob didn't know that his heart attack was coming on Monday. If he had known, he would have taken his aspirin, right? So it's interesting. I gave up working Mondays in the ER a long time ago for a very big reason. They're busy, there's a lot of stuff going on, and people don't want to go to work also. So you're seeing a big mix of really sick patients and people that don't want to go to work. So, okay, fine, maybe I'll work a Monday here and there, but they're not my favorite day to work. My favorite day to work, Wednesday, least amount of patients, least amount of trouble, and least amount of death. Now, in the beginning, I loved working all the busy days, but now I really want to take a nap some days. And we all need those once in a while. But who is at high risk? Who are our patients that are at high risk? And Rick Pescatore was talking briefly about the polypharmacy, and we're going to discuss that in a minute. But what are the other things that put people at a big risk for returning back to you? So you've done your job. You've learned, like I said, all the stuff here, and you're applying it, but sometimes they still come back. Well, these are the people with circulatory system diseases, respiratory disease, infections, GI diseases, mental health, accidental injuries. That takes us back to this list that I showed you, right? These people are coming, and they're coming again. So remember that the rate of 30-day readmissions are consistently highest among the patients who stays billed with Medicare, then Medicaid, then our uninsured patients, and then our private insurance. So know who is at risk so you can identify them early. And the polypharmacy, know the drugs that are most associated with polypharmacy complications. We know that antibiotics cause a lot of side effects, but so do steroids, anticoagulants, opioids, antiepileptics, so on and so forth. So if you are familiar with the fact that these medications may be troublesome for patients, then you may be able to pick up on something earlier, going through that med list with your elderly patient, setting up a primary care doctor's appointment, etc. And then anybody that's diagnosed with more than 6 conditions, certainly we know that they're going to have more complications. Any prior hospitalization that they've had in the last 12 months put them at higher risk for coming back again. And there is some literature that suggests that Black race, lower health literacy, people who live alone, lower socioeconomic status, and those who leave AMA are at definitely higher risk populations. So as Diane would mention, for the vital signs, did you go back in the room and check the vital signs? How did they look? Did they improve? What is normal? What is abnormal? Do your critical thinking skills, not just when you first see the patient, but when you're also discharging the patient. What might you have overlooked, right? Have a little checklist for yourself. And then, what did you find? And you need to communicate that to your patient. Now, what happens if you have incidental findings? And we did briefly discuss this. What I like to do is if someone has an incidental finding, pulmonary nodule, something else that they need to follow up with that may not be an emergency today, they need to have it on a sheet of paper, you give it to them and highlight it. Now, an incidental finding saved my life from one of my favorite ER physician friends many years ago. I went to the emergency department. I had a horrible headache. It was the worst headache I've ever had in my whole life. And I got the whole workup of the CT of the head and the neck. And I ended up being fine. It was migraine. It was just really severe. But remember, my physician came in, who was my friend, but also does this for every patient. And he said, you know, I found something on your CT. It looks really normal to me, but the radiologist really, I think it was an overread, maybe, I'm not sure. But he's like, I'm just gonna, go through this with you. And I had a mass in my neck. So I followed it. I didn't make a big deal about it, but tons of times there's incidental findings that are kind of overreading or hedging by the radiologist, and we don't really think much of them, right? A couple years later, I went back to the doctor and said, hey, I got this piece of paper that says this information, what should I do? I ended up getting more imaging on my neck. It turns out that I, had a big growing tumor in my neck. I had a big Hürthle cell tumor. And for any of you that have seen my big scar, it's a reminder that ER doctor ultimately saved my life many years down the line. So I'm very grateful to him. So the other things that are really important is setting up appointments for your patients. Now that seems like a real big pain in the ass, but I'll tell you, once you work in a place for a long time and you start seeing that primary care doctor's name on the patient's chart, it's really easy to call the office and say, so-and-so is here, I'd like to schedule an appointment for them. It's easier than you think, and there's always a backline for the office. And then, of course, do the patients have any questions? Answer their questions. Don't just breeze by the door and say, hey, everything looked fine, got any questions, okay, bye, right? We need to make sure we go in and talk to them. And the way that we talk to them is really important. We don't talk at them, we ask them to talk back to us. And that is the Ask Me 3 approach by the National Patient Safety Foundation. They essentially say, please ask your patients the following 3 questions. If you do and they can answer them correctly, they more likely will do better upon discharge. So you have them say, what was my main problem? Well, I was here today because I had an abscess. Okay, then have them say, what do I need to do? Well, I need to come back in 2 days, right, you said, and have the packing removed. And I say, yep, that's right. And then ask them how they're going to manage it at home and if they run into any problems. Well, if I have any problems with my abscess, and then they might say, I'm not really sure. You say, I want you to come back right away, especially if you have a fever, and that's when you can interject. It's a conversation. And then lastly, you want them to tell you why it's important. Why would they even care to do these things? They need to communicate with you why they think it's important and why you think it's important. 40% of patients are unable to describe the reason for their hospitalization. Oh, I went to the hospital. I don't know what my problem was. They said there was nothing wrong with me, right? But we all know that we do more for patients than that, right? At least I hope we do. More than half of patients can't even recall the discharge instructions or their follow-up appointment. That's our fault, right? So in some cases, yeah, you can't teach patients. You might tell them again and again and again. And so I understand that it's difficult, but in the end, it's our job, it's our responsibility to help these patients navigate. Of course, there's going to be a patient that you know what, it's a tough day for them, but we do the best that we can. So work on these teach-back techniques. They're very useful. And then also the Society of Hospital Medicine has a checklist. You can check that out as well. What should be on the paperwork? What's important? Well, a lot of things. We've got to put the patient's name. We've got to put your name or the physician's name. We need to put the purpose of the discharge instruction. Well, they were here for such and such, and they got a diagnosis of blah, right? So potential complications need to be listed, as well as medications and side effects. Now, I don't particularly love the medication printouts that come with our paperwork, and every institution is going to be different, but I'm going to show you some smart phrases that you can literally directly copy and use if you like. I've had them all reviewed by JDs, MD JDs, to make sure that they were A-OK. You also want patients to have a follow-up plan, which I'll show you, and then documentation that they receive the information. And people are like, well, hey, what if they don't take the paperwork? What if they throw the paperwork in my face and say, screw you, you didn't help me at all, right? Well, hopefully that's not the situation, but once in a while it happens. Well, you do your best to document that you went over the information with the patient refused to take the paperwork with them. You can also attempt to mail the paperwork to the patient. I worked in an institution that emailed the paperwork to the patient, didn't even have paperwork at all. If they didn't have an email, then certainly we printed it off for them. The other thing I like to tell people is I give every patient my email. When I started telling people that at prior courses, they were like, oh my God, why would you do that? Well, you know what? I give my patients, hundreds of patients, my email. Maybe for every 100 patients, one writes me. Maybe once in a while I get a really nice letter that says, hey, this incidental finding ended up being nothing, but thanks for, helping me get this appointment or whatever. It's so gratifying to know how some of your patients do. And also, if you can fix something very easily in just 1 to 2 sentences in an email, I'm not talking about like the patient writes you and says, I have chest pain, what do I do? They're like, hey, you said you were going to write me for 7 days of Keflex, but the pharmacy says they only have 5. Now, what if that patient just decided to come back to the ER and go through all of that? To me, if I can take care of something that easily, I do it. Now, of course, everyone's schedule is different. You shouldn't have to be on 24/7. This is just something I do, and my patients really enjoy it. Otherwise, going back to the discharge paperwork, if you don't put all this stuff, now the email is certainly optional, right? And there is some liability there, so you have to be careful. But if you don't put all this stuff, then the patients are going to say, nobody ever told me that. I didn't know that. But again, half our patients say we never did anything for them at all. So as we talked about in the very beginning, I wanted to just quickly run through each of the 10 complaints. Essentially, 1 out of every 10 patients is going to have abdominal pain. 25% of the time, 1 in 4 patients, not going to find anything wrong with them, at least not today. But that's where it's important to say to the patient, well, we did this workup, this was positive or this was negative, we didn't quite find the cause for your issues, but these are the reasons I would like you to come back if you're worse, or this is your follow-up plan. Put your hands back on their belly, push again and make sure that you're not missing something, check their vital signs again, and then document the following things. Abdomen soft, non-tender, no guarding. Patient is much improved. Patient expressed to me, I feel so much better. The patient is tolerating PO fluids, ate a turkey sandwich, right? Witnessed family member bringing in McDonald's, ate 2 bacon cheeseburgers and 2 Diet Cokes. Non-distressed, eager to leave. Chest pain. So about 5 to 8% of your visits, most likely you're going to see a chest pain on every shift. So you need to consider the age, the presentation, and the risk factors before you discharge this patient. And as Jess was saying, you know, if a patient just developed pain, you're going to hang on to them for a little bit and do a couple of extra tests, right? You might want to repeat a troponin, you might want to repeat the EKG. And for patients that have other concerning issues, you might want to put them in your observation unit, right? You might want to get a consultation. So when you're discharging that chest patient home, did you go through your document keys of the hard score? Did you think about PERC? Right, perking them out and thinking about PE. Did you think about other diagnoses, right? And again, as Diane would say, vital signs, vital signs, vital signs, they're vital. Back pain. Again, a large percentage of what we see in the emergency department, you're going to see one almost every day. And the key for documentation here, and we have discussed this throughout the course, but you should make a smart phrase for this. And again, I know Jess, again, trying to bring in everything from the course, she had mentioned putting these particular things as a checklist for herself. There's no shame in that. Why not you have to be responsible for thinking about so many things on your shift. Why not put some of these in there just to remind yourself? I also like to put this in the chart when I'm discharging a patient. I document the sensation, their motor, their movements. I said I watched the patient walk up to the bathroom. I didn't have to assist them. The patient voided. They had a normal BM. They told me they were able to go to the bathroom on their own. You know, I can make comments about their general mobility, and then no signs of cauda equina, and based on the following things. And I would list those out specifically, not that sort of random sentence that, if you recall from the first day, Rick told us, you know, it was just kind of vague and totally useless. Be very specific. For patients with a cough, remember what I said during the upper respiratory talk and cold and flu? Basically tell them their cough is probably not going to get better tomorrow, right? Give them that work note. Tell the smokers that it's going to take a little longer for them to get better. And also give them strict return precautions, which we talked at length in that talk. So I'm not going to bring that up again, but make sure you bring them in there. The other concerning features that you want to rule out, right, are, hey, I got a chest x-ray. Chest x-ray looked clear. I reviewed the report from the radiologist. I looked at the images myself. Those kinds of things are what you want to put in your chart. And again, vital signs. The patient appears non-toxic. And you can further identify non-toxic as saturation 99%, heart rate is 80, so on and so forth. Our asthma and COPD patients, the key here that I want everybody to take away is you have respiratory therapists, most of you in your department. Now, urgent care might be different. Respiratory therapists are great, and if they're not busy, which frequently they are, they will come in and help teach the patient how to use a spacer, or help come in and show them or give them techniques on how to quit smoking. And remember, you can bill for that discussion, that 2 or 3 minute discussion with a patient. And of course, it shouldn't be like, you know, you need to quit smoking. Okay, you wouldn't be here today and you wouldn't have COPD if you didn't smoke, right? So, of course, as being someone that did smoke at one point in their life, I know it's crazy, right? We all make bad choices. That and the sparkle shoes. So, when it comes to making bad choices, telling somebody to not smoke to me is, I start off the conversation like, oh man, you know, I see that you smoke. I didn't start it off in the very beginning and criticize them. I just say, hey, you're still smoking? Yeah, I smoked for some time. I know how hard that is to quit. I failed many times. What kind of cigarettes you smoke? And again, this reminds me of Rick's talk. what kind of cigarettes do you smoke? They say, oh, Marlboro Reds, right? Or Lucky Strikes. And you're like, hey, why don't you switch to something a little lighter? Don't switch to a vape, but why don't you try like an American Spirit or something that has like a filter on it at least, like something else to try and help you cut back. And if they say it's never possible, I've got COPD, there's no hope for me, say there's always hope, right? And you can give them some materials and level with them, It's not an easy thing to quit. For our pediatric fever patients, complete and document a full exam. Go back to Bucata's talk, look at the notes and see that you got to go and tell the mom, yeah, Johnny's belly, nice and soft, heart sounds normal. I've gone through the whole exam, right? I've made sure, I've been talking to the mom. Okay, everything looks good here, right? And as he said, there's only so much surface area right on that kid. You should be able to do this again in 30 seconds. Review Motrin and Tylenol regimens with parents, okay? It's difficult. They're stressed and they haven't been sleeping. You need to go over it, write it down for them. Don't just tell them, go to the CVS and get the Tylenol. Give them a dose. You can do that. It's easy. And then document, does the child look sick, right? Vital signs, activity level, tolerating PO fluids. Are they feeding? Those kinds of things. Laceration. This is my smart phrase for laceration repair. Feel free to steal it. Today you had a laceration to your finger. We placed 8 sutures. They need to be removed in 7 days. You can do this at your doctor's office, or you can come here if necessary. We've updated your tetanus shot today. Then we give them a copy of the tetanus information. If you smoke, it's going to delay your healing, just FYI. And then, of course, in your chart, you're going to document that the bleeding was controlled, neurovascularly intact, there's no tendon involvement, full range of motion, things like that. Fractures and splinting, remember to speak to a specialist about all the fractures if you possibly can, if they're on site. If they're not, this might be another good time to try and set up an appointment if you can. It really depends on your institution and your comfort level with orthopedics. But just remind the patients, don't get the splint wet. These are all the things that you know, but if the patient knew it, they wouldn't be there, right? So we can't give them that much credit, right? We have to be able to tell them what they need to know. And again, the documentation keys here, especially if pain control was given in these long bone fractures. Sometimes they get splinted and go home. Some of them don't go to the ER or the OR right away. There's the CMS measure that we need to make sure we give them a certain amount of pain medicine in a certain amount of time. What about those inconclusive diagnoses? I'd like to just say, if I couldn't figure it out, so-and-so couldn't figure it out yesterday. We just don't know. But again, you got to be really careful with the inconclusive diagnosis, because you want them to continue seeking care for their problem and not feel like that they're being given up on. So I like to say, today we did this whole workup for whatever. Sometimes we don't always find the cause for your symptoms of the cause for your issues during your ER visit. And then I put in a little phrase about what we found and what we didn't find. And basically it's the same for every patient. We want you to follow up. We want you to read the discharge instructions. Here's my email if in a severe emergency. And by the way, if there's any time I can't answer an email, I simply say return to ER immediately. Motrin and Tylenol smart phrase, you can steal this and take it. You can make your own. And essentially you can dot phrase that in if it's easy for you, or make a handout. Most of us already have this. And opioid smart phrase as well. Now these get tricky, right? So there's one smart phrase for the doses and how to use it. And I've already described that I don't prescribe Percocet. I really, really don't. I prescribe Tylenol or Roxy or Oxy or whatever I want. That's just, I like this drug, and I like pairing them the way. Now, some may say polypharmacy can be dangerous, but for me, if they get pain relief with 2 Tylenol, why waste their time with that opioid? So you can spell that out in some discharge information, and it will be very clear for what patients need to do. Always putting in for a stool softener if they are on opioids. Note that it's addicting. And then patients with chronic pain seeking opioids, right? So we always know there's a patient that once in a while they're like just there because they want a refill. You can put something in there like, this patient has chronic pain. We had a conversation about multiple evaluations and workups. I explained at length that I was ready to address the complaints appropriately, but I stressed the importance of safe care and did not disregard or dismiss the complaints, but explained that I was quite concerned about their dependence, misuse, or potential abuse, and then talk about what you did about doing a stabilizing exam. Again, this is just more information that you can use for your chronic pain and your smart phrase. This specifically talks about maybe how you're not going to give the pain medicine today, and that's why. but at least you've addressed it. Okay, finally, your signature. As we already talked about, email address can go in there. Dear Dr. Bucata, your diagnosis today is, what should we give you today, Rick? Let's give you back pain. Your diagnosis today is back pain. Generally, you should start to feel better, never, really. No, I'm only kidding. You're going to start to feel better in a couple days. If you don't improve in 5 to 7 days, follow up with the specialist provided, Dr. Smith. And why did I say Dr. Smith? Because I made an appointment with him with Dr. Smith. In addition, I like referring people to a specific person in the group. So don't just say, go to UC Davis orthopedic group, right? Say, oh, I love Dr. Jones. Dr. Jones is awesome. Even if Dr. Jones is a real dick, maybe he's a great doctor, and you can follow up. Oh, and he has a PA that's super nice that you can really get an easy appointment with. You know, patients want a name. They don't just want a group. They want to know something. Again, we already talked about smoking. This is just some information that you can add. I also like to tell people to see a dentist. I have a nice little signature that's about a half a page long. Sometimes they read it, sometimes they don't. And then remember, just some last additional resources that you may want to consider. Put the images on a disc. Super easy to do. Get your scribes to do that for you. Print out the lab testing. Highlight things that are abnormal. Put the phone number and address of your facility. Maybe homeless shelters. Talk to your social work if you need that. Again, with addiction specialists or suicide or mental health referrals. You never know what someone might pull out of that information packet and actually apply. And again, some people have a primary care. Who's taking new patients forms? So it's easy. I also created an entire dental resource list for my last hospital, and I'll tell you, not only were the dentists very pleased to have the wealth spread around, okay, patients had options. Bonus points, if a pharmacy is closed, maybe dispense them a single dose of the medication if your department allows it. And then also consider giving ear drops or eye drops. So let's say, like we had the video putting in the earwick. If I had actually used real medicine, then what am I going to do, throw that bottle away? Now, some of the nurses say, yes, we have to throw that away. We can only give it in the ear. We don't dispense. There might be some wiggle room there. Check with your administrators and check your policy. Like I said, finally give a name of a specialist. That's a picture of Jim down there. Okay. Carrying callbacks. For those of you, like I already talked about, calling patients, I call some patients back just because I'm generally interested. Like, what the heck happened to them, right? Hospitals may force you to do this, but once in a while, if you make it fun and interesting, you might actually not hate it. Lastly, everybody wants to know, how do I get my certificate, right? All right, this has all been well and good, but how do I get my points? How do I get my CME credit? Tell me everything, right? So this is what you need to do. Go to your account and take your survey, okay? Give us your feedback and let us know. I know your time is extremely valuable, and having the survey in front of you is a couple of questions. It probably takes 2 minutes to do. And then you'll be able to download and print your certificate. The live stream, like I said, has been spotty for the course, but there are some of the lectures available, so please take a look. And as I mentioned, we typically make this live, so September and December, if you check the website, tune in for one of the courses. We do the same course with a little updates in December, and then the advanced course is in September. Finally, the Slido questions will be emailed to you. As Dr. Bucata already mentioned, you're going to get a disc card thingy sent with the lectures. And for any other questions, you can always call the office. I'm sure Colleen would love me to field as many questions as possible before you go. So feel free to come and ask me, and I'm happy to help. Just remember, as you go out on your planes and then we discharge you out into the world with your suitcase, just remember the 3 C's, right? So it's not COVID, COVID, COVID. It's be calm, be critical thinkers, and always be compassionate. So thank you very much. Rick's going to say his formal goodbye.
Are there no questions?
Any other questions?
No. Isn't there a question thing today?
No question and answer today.
No?
No. I know, it's so sad.
Take
care, everyone.
I had a lot of answers. All right.
Did you have something else to say, sir?
Yeah.
Do you like your picture? Bye for now.
Thanks a ton for coming. I hope you enjoyed it. Please take the manual home. Study the manual when you have the opportunity, and there's a patient that's kind of appropriate for review there. Share the manual with other people if you can, so that they can get some of the benefit potentially out of it. And just keep an eye on our channel, ccme.org. It'll tell you what kind of programs we're doing, what other things are going on. We do have a pediatric course coming up probably in the first quarter of the next year, which is, I think it's going to be a rock'em sock'em pediatric course. We've got some great people participating in it. In any case, thank you very much for coming. And our faculty. I want to thank the faculty who really make a big sacrifice to come here, especially at 114 degrees in the airport that's not very nice right now. Thank you, guys. And the AV department, Chris and Dave. They are here like 14 hours a day to make this stuff work. They have a great enthusiasm for doing it well, and I really appreciate them now. Okay, bye now.